ओके, तो ध्यान से सुनना इसको। कुछ करना है तो डट कर चल, कुछ करना है तो डट कर चल, थोड़ा दुनिया से हट कर चल। कुछ करना है तो डट कर चल, थोड़ा दुनिया से हट कर चल। लीक पर तो सभी चल लेते हैं। लीक मतलब लाइक पाथ, जो बना बनाया पाथ होता है उस पे। पाथ लीक पर तो सभी चल लेते हैं, कभी इतिहास को पलट कर चल। बिना काम के मुकाम कैसा, बिना मेहनत के दाम कैसा। जब तक ना हासिल हो मंजिल तो राह में आराम कैसा। मतलब इस लाइन का मतलब देखना कि बिना काम के मुकाम कैसा, बिकॉज विदाउट डूइंग द हार्ड वर्क, विदाउट स्टडिंग यू कैन डू एनीथिंग। एंड बिना मेहनत के भी कुछ हासिल नहीं होने वाला, बिना मेहनत के दाम कैसा। जब तक ना हासिल हो मंजिल तो राह में आराम कैसा। डोंट स्टॉप नाउ। अर्जुन सा निशाना रख, अर्जुन सा निशाना रख, मन में ना कोई बहाना रख। अर्जुन सा निशाना रख, मन में ना कोई बहाना रख। लक्ष्य सामने है बस उसी पे तू निशाना रख। लक्ष्य सामने है बस उसी पे अपना ठिकाना रख। सोच मत साकार कर, अपने कर्मों से प्यार कर। सोच मत साकार कर, अपने कर्मों से प्यार कर। मिलेगा तेरी मेहनत का फल, किसी और का न इंतजार कर। मिलेगा तेरी मेहनत का फल, किसी और का ना इंतजार कर। जो चले थे, ये वाली लाइन ध्यान से सुनना, जो चले थे उनके पीछे आज मेले हैं। जो चले थे उनके पीछे आज मेले हैं। जो करते रहे इंतजार, उनकी जिंदगी में आज भी झमेले हैं। ठीक है, तो इस वजह से आई होप ये आपको अच्छे लगी होगी पोएम। ठीक है, और इसको अपना मतलब ये इसमें बहुत काफी चीजें मिली हुई है। सो दैट यू नीड टू बी एक पर मैं थोड़ा सा इसको इंग्लिश में ट्रांसलेट कर देता हूँ। दिस पोएम वांट्स टू से कि इफ यू वांट टू डू समथिंग, like if you want to do something, if you cannot run then you walk, if you cannot walk then just sit but do some work. Then if you like every step you need to move a little, and everyone's in this world they follows their paths, like the it's artificial path everyone follows. But if you want to create some history, then you should follow your own path, or you should create your own paths. Tell me what is the destinations without works, and what is the value without hard works. So there is a no value without hard works, and there is a no destinations without those hard works. Unless the destination is achieved, there is a no rest on the way. Once you will get the on the your destinations, you can take the breaks. But if you didn't able to reach to the destinations that you should having, that keep going to the till your destinations has been come. Then in the mind you should having that focus, that okay, you need to be focused on your goals, and you will get the fruits of your hard works the later on. Once you will get the hard works, okay, that's enough I think. Rest I will create a new English poem also. Okay, so let's start, because we completed the two subjects also. So these two subjects, they are the like you create already 50%. Now 50% you have to study, and in this 50% you have to study the therapy and the surgery. So these are again the most important topics that you need to study. So be focused, because we have just 1 month. Don't include the May also, because May will also include, May is also in the revision only. So that's why I'm saying you have just this April and April only. So if you have some work off and anything, please manage everything. I don't know how you will manage, but you should have to manage everything. So let's start. From the question number 1. Okay, a 76-year-old woman complains of progressive swallowing disorder. So see, a 76-year-old is there, they having the swallowing disorder. Mostly she had a problem with the solid foods. So now you see, if you having the problem, if you see the questions, in which there is a swallowing problem. Means swallowing means dysphagia. Swallowing means dysphagia problem is there. Mostly she had a problem with the solid foods, not liquid for the last 6 weeks. Sometimes she has a regurgitation of the solid mass. Swallowing is not painful. She lost 6 kg. She lost 6 kg. See, if you see anything weight loss, if you see the weight loss, so means that is talking about something about the cancer. Think maybe the cancer can be the answer. The 10 years ago she had myocardial infarction. She take constantly aspirin and prolonged nitrates. She consumes alcohol in the moderate proportions and the smokes. Objectively ecteric skin, neck has no peculiarities, lymph nodes are not enlarged, thorax has no changes, cardiovascular system. So they explain all the systems, and liver is plus 3 centimeter. What is the preliminary diagnosis? So this answer is the cancer of the esophagus. So let's discuss about the dysphagia. So when we talk about the dysphagia, so in the dysphagia, if we talking about the esophagus, so esophageals we having the two problems. The one conditions we call that is the achalasia cardia. First conditions we can having also the Jenkins diverticulum also, but let's first discuss about the achalasia cardia. Achalasia cardia. What is the achalasia cardia? In case of the achalasia cardia, what we will see? We see there is a failure of relaxation. There is a failure of relaxation of lower esophageal sphincter. I hope every one of you know the esophagus, they opens into the stomachs, and once they open into the stomachs, we have the sphincter there, and we called it as the esophageal, gastroesophageal sphincter or the lower esophageal sphincter. So this they will relax when the food will go from the esophagus into the stomachs. They will relax, but if this relaxations will not occur, this we called is the achalasia cardia. And why there is a failure? This failure is due to absence of ganglionic cells, due to absence of the ganglionic cell in Auerbach plexus of Auerbach plexus in esophagus, Auerbach plexus in the esophagus. So this will be the ganglionic cells in the, what is the Auerbach plexus? The Auerbach plexus is also known as the Auerbach plexus, it is also known as the Meintrich plexus. It is also known as the Meintrich. We know that we have the mesenal corpuscles and we have the Meintrich plexus. The Meintrich plexus, they are the mucosal. They are the mucosal. So if ganglionic cell is absent in the Auerbach plexus, ये क्या है? Due to absence of the ganglionic cell in the Auerbach plexus in the esophagus or the Meintrich. So we call this as the Auerbach plexus. If they will ask you the tone of esophagus, if we talk about the tone of esophagus, so always remember the tone of esophagus is maintained by the acetylcholine. The tone of esophagus is maintained by the acetylcholine, that is the neurotransmitter of the parasympathetic. So if there will be the relaxations will not occur, so esophageal peristalsis will be absent. And also remember, it can be the primary regions, the primary achalasia cardia, or it can be the secondary. If we talk about the secondary, it is associated with the scleroderma. So this you will get in this question, something related to the in history, that this condition is associated with the scleroderma, this condition is associated with the Chagas disease, these conditions can be associated with the diabetes mellitus. So maybe they will get the history that this patient having the diabetes mellitus, and then they have problems with the liquids, the solids, all these have the problems. Okay, what are the clinical features we will see? See, I am telling this is the conditions where we having the dysphagia problems. So the first or the commonest feature we will see that is the dysphagia. In the dysphagia we have the two things. It can be the problems in the swallowing of the solids, or it can be the problem in the swallowing of the liquid. So if we have the dysphagia, so initially what we see, initially there will be the swallowing problem for liquid. Initially the swallowing problem for liquid. Why initially the liquid problem? See, this is my esophagus. Now there is a problem in the relaxations. So if any solid particle or the idli or the anything is coming, the solid particle is coming. So see, they will put the pressure, and due to this pressures they will be go in. They will become inside, or they will be completely easily swallow. But once they will be accumulated here, there will be the progressive swallowings we will see in case of the solid also. So what we having, the gradually for both solid and liquid. So gradually for the both solid and liquid. So this is very important line because it is differentiate us from the esophageal cancer. In the esophageal cancers, we will be having the dysphagia, firstly the solid and then liquid. So initially what we see, the swallowing problem for the liquid, and gradually for both solid and the liquid, because those solid will accumulate, and now once they will accumulate, the solid will also not able to go down. That's why we see the gradual loss in the solid also. Okay, other clinical features we see like the regurgitations. We see there is a regurgitations will be there, aspirations can be there. Aspirations means that can go to the trachea also. If food particles go to the trachea, that can cause the pulmonary complications. Okay, I hope this is clear. Now this is what this achalasia cardia. And achalasia cardia, remember, I am writing it here further. In achalasia cardia, if we want to do the investigations, so the first investigations we do, that will be the barium swallow. We discussed in case of the pediatrics what is the barium swallow, what is the barium enema, everything we already discussed. After that, if we check about the in case of the barium swallow, what are the signs we will see? The sign that we will see, that is the important sign. It can be the bird beak appearance. The bird beak appearance can be there, or the pencil tip appearance can be there. The bird beak appearance can be there, pencil tip appearance can be there. The other sign that we can see is the rat tail sign, but rat tail sign I am not writing it here because the rat tail sign, they are more common that we seen in case of the esophageal cancer. So let it be for the esophageal cancer. And if we see in the question bird beak appearance, that means it talking about what, which condition? Achalasia cardia. There will be the achalasia cardia will be there. Okay. Then what are the standard investigations we can do? That is the monometry. We can do. But monometry I am not writing here. I am writing here about one condition, that is diffuse esophageal spasm. I am writing one condition here, that is the diffuse esophageal spasm. In case of the diffuse, as we see, the diffuse means complete. So esophageal spasm will be there. And in that conditions, if we check about the normal intraesophageal pressures, so that will be the 300 to the 400 millimeter of mercury. 400 millimeter of the mercury will be there. Okay. In this condition, what we will see, the corkscrew esophagus. The corkscrew esophagus will be seen in case of the diffuse esophageal spasm. Like for example, this type of the esophagus will be seen. The esophagus will be looks like the corkscrew. So we call this as the corkscrew esophagus. Okay. So this one we discussed. Where we will see the corkscrew esophagus? Again on the barium swallow. I hope this is clear. Now treatment they will not ask you for the eclasia cardia. If they will ask you the treatment for the eclasia cardia, remember we can give the dilatations like the calcium channel blockers, nitrates वगैरह. And there is a treatment of the choice for this condition, the myotomy. We will cut those muscles that we call the myotomy. Okay, but that they will not ask you. Okay. Okay, after that let's discuss about the esophageal cancer. Or let's discuss it here only. Okay, other questions we will discuss further on. So what is the esophageal cancer? The second one that we are discussing, that is the esophageal cancer. So when we talk about the esophageal cancer, so this is again what we have cancer. The first findings that we will see in this question, we will see that there will be the first things that we will see, there will be the weight loss. So if in the Crow 2 questions you see that in the patient is given, and in this condition we are seeing the weight loss. So first thing that should come in your mind about the cancer, but don't mark this, read the full questions and then answer the according to the question. But first thing that should come in your mind, that it can be the cancer will be there. If we talk about the esophageal cancer, if we देखो any external opening is there, any external opening is lined by the squamous epithelium. Any external opening, you can write one line, any external openings, whether it is the anus part, the mouth part, the oral cavity, or all these, any outer opening is there, is lined by which epithelium? The squamous epithelium. So esophageal cancer, the most common esophageal cancer is the squamous cell carcinoma. Squamous cell carcinoma. So squamous cell carcinoma will be there. And also remember the upper, it involves the upper 2/3 is the more common. If upper 2/3 is not in the option, then middle 1/3. Middle 1/3. But if we talk about the esophageal cancer in the Western peoples, the most common in Western peoples. The Western peoples, what they do, they will be having the most common adenocarcinoma. Adenocarcinoma means, adeno means involve the gland. They involve the glands. So adenocarcinoma include the lower 1/3 esophagus. Okay, upper 2/3 and the upper 2/3 and the middle 1/3, that involves the squamous epitheliums. Lower esophagus, it involves the columnar epitheliums. Then remember the adenocarcinoma, this is the most common in the Western peoples, because Western peoples, what we will see, the reflux disease. So it is due to GERD, because they involve the spicy food and all those foods that will cause the reflux disease. So that's why they will be having, the more common is the adenocarcinoma. The risk factors you can easily understand, that can be the smoking, that can be the alcohol, and eclasia cardia, the GERD, the Barrett's esophagus, all these are the risk factor that we seen in case of the esophageal cancers. The important things that you need to remember here, that the clinical features. If we talk about the clinical features in esophageal cancer, that again the dysphagia, that is again the dysphagia. And dysphagia, it is the most common and earliest symptom. The most common and the earliest symptoms we will see in these conditions. Now remember, if we see the dysphagia, the difference between how you will able to differentiate the eclasia cardia and the esophageal cancer, that in case of the dysphagia, initially we will see the dysphagia for solid. Initially dysphagia or the swallowing problem for the solids, and then gradually for solid, both solid plus liquid, the gradually for the both solid plus liquid. In also this we will see the aspiration problem, pulmonary complications, and also in this condition we see the hoarseness of the voice. Also we see there is a hoarseness of the voice, also see hoarseness of voice. Why the hoarseness of the voice? Due to recurrent laryngeal nerve involvement. Due to recurrent laryngeal nerve involvement will be there. Other than that, what we discussed? We discussed the weight loss. So this is what weight loss, and weight loss we know that it is associated with the cancer. So other conditions what we discussed, that is the weight loss. The weight loss, hoarse of voice, dysphagia, and in the dysphagia initially for the solid and gradually for the solid and the liquid. Because in esophageal cancer what we are seeing, this is the esophagus, if this is the esophagus, okay. So in this condition what we see, if this is the normal esophagus, but in case of the like for example if we say that this is what we having the cancer, esophageal cancer. So here we can say it will become the narrow due to cancers. So that's why there will be the firstly the problem with the solid, then gradually for the both solid and the liquid, because once the cancer progress it will be completely blocked, and after that the liquid will also not able to pass. That's why we see that in this condition also the investigation, if we want to do the investigation, the same investigations we do, that is the barium swallow. But in the barium swallow we don't see the bird beak appearance, in which we see the filling defect. What we will see, the filling defect will be there. Like if we see this is the blue, white, and then there will be the one line like white lines, and then it will be again this. So this we call the filling defect. This will be the filling defect will be there. Other than the filling defects, what we will see, we see there is a rat tail appearance. There will be the rat tail appearance. In these conditions we also see the apple core appearance, like किसी ने सेब काट के खा लिया. So that is the apple core appearance, or apple has been whitened, so that will give the appearance of the apple core appearance. Again I am not writing it here. Why I am not writing here? Because apple core appearance, that is a mostly seen in case of the barium enema in colon cancer. Okay, just keep this in mind. Apple core appearance is seen in colon cancer. In case of the, when we give the barium enema, we see in case of the colon cancer. Also we will see in case of the esophageal cancer as well. Okay, when the cancer will be at the periphery, so it will looks like the apple core appearance. Okay, so it is seen in case of the both apple core appearance, but mostly the apple core appearance is associated with the colon cancer. Like in the question they will ask you apple core appearance regarding to the colon cancer also. But also remember the apple core appearance can also be seen in case of the esophageal cancer as well. So read the questions carefully and then answer. Okay, is that clear? You can take the screenshot of this if you didn't write. Okay, now I hope everything is clear. So we are having the problem with the, mostly she had the problem with the solid foods. Mostly she had a problem with the solid food for the last 6 weeks. Sometimes she has regurgitation of swelling food. That's why we will be having the cancer of the esophagus. Also we see the weight loss is there. And that's why it is the note the esophageal spasm, okay, eclasia. Diffuse constriction of esophagus, what we discussed, there will be the corkscrew appearance. Corkscrew appearance will be there. And of course it is not associated with the diaphragmatic hernia, myasthenia gravis. It is not related to that drugs. After that, question number 2. A 65-year-old woman who has a problem with the urination as a result of the benign prostate gland adenoma. So we are seeing this condition that there is a benign prostate gland adenoma. He developed the fever, chills, hypotension, sinus tachycardia. So if there is a decrease in the blood pressures, if there is a decrease in the blood pressures, increase in the heart rates, what we call these conditions? What we call these conditions? We call these conditions that we seen in case of the shock. So these patients will be having the septic shock symptoms. This patient will be having the septic shock symptoms because we have seen that the patient is having the fever also and the chills also, that we seen in case of the septic condition also, septic conditions. The skin is warm and dry. Clinical blood analysis reveals absolute granulocytopenia. We know that we discussed the absolute granulocytopenia. This condition is again associated with some bacterial infections. These hemodynamic changes are most likely to be caused by. So bacteria, what they cause, they release the endotoxins that will cause the endotoxemia, and endotoxemia is associated with the septic shock. It is associated with the septic shocks. So once it involves the complement system, so what happens when this patient having the fever, the chills, decreased blood pressure, increased hypertension, warm, dry skin, absolute granulocytopenia, all these are the symptoms of the septic shock. So when the activation of the complement system, so if any phagocytic activities is there, the complement systems becomes activated. If phagocytic activities is there, then this complement systems will become activated. What are the complement? Are we giving any complications to anyone, or are we giving any complement to everyone? No, it is not related to any complement. It is what? It is a plasma proteins, and these plasma proteins, the complement, it is what? These are the plasma proteins, and these plasma proteins, remember, these plasma proteins activated by any pathogens or activated by the antibodies that is produced in presence of these pathogens. So these are activated by the pathogens or antibodies that is produced in presence of these pathogens, that will cause the activation of complement systems, and after that there will the cascade of the reactions will be there. The cascades of reactions will be there that will help in phagocytosis. Okay, and that's how it causes the endotoxemia. Okay, so this question is not about the benign prostate hyperplasia. This is just to confuse you. This question is about the septic shock, and it is including how the complement systems will be activated. So if any phagocytic activity, complement systems will be activated. After that, the next question, a 60-year-old man complained of the sense of heaviness. So what we are seeing, there is a sense of heaviness, भारीपन लग रहा है in the region of the scrotums, कुछ बड़ा बड़ा फील हो रहा है. The scrotum edema in the left part. So what we are seeing, left part के अंदर scrotal edema दिख रहा है, यानी कि scrotum सूजा है किस तरफ में, left part में. The scrotum edema will be seen in the left part. Testicles कैसे हैं, normal size के हैं, कोई problem नहीं उनमें, but there is a soft scrotum limited edema over it and can be pressed and disappear when the patients lie down. जब ये क्या हो रहा है, pressed when the patients lie down, जब patient सो जाता है, सोने की पोजीशन में आ जाता है, तो वो जो एडिमा है वो disappear हो जाता है. When he lie down, this all the edema will be disappear. It means it related to something like gravity. मतलब जब बंदा खड़ा है तो उसको एडिमा है, जब बंदा लेट गया तो उसको कुछ वो disappear हो गया. When the person is standing, we see there is a edema. When the person is horizontal, means the edema has been disappeared, means something is related to the gravity. There is a gravitational force is there. So what is the preliminary diagnosis? The preliminary diagnosis is the varicocele. So let's discuss what is varicocele. See, when we talk about the varicoceles, So varicocele, it is like the abnormal dilatation of the pampiniform plexus of the veins around the testis. अरे ये क्या बोल दिया, क्या क्या कर दिया, ठीक है, बहुत कुछ चीजें हो गई हैं. Now let's understand what is that. What do I discuss? Abnormal. Okay, it's not normal. Dilatation, something is dilating of what? Which pampiniform plexus? Pampiniforms. Pampiniform plexus. Okay, abnormal dilatation of the pampiniform plexus of veins around the testis. What is the plexus? The plexus means this is like the network of the any vessels or the nerves. The network of any vessels or the nerves, we call this as the plexus. Okay, so if there is a abnormal dilatation of these pampiniform plexus of the veins around the testis, we call this condition as the varicoceles. Now see, everyone having the two kidney? नहीं, जरूरी नहीं है. Somebody can have one kidney also. With one kidney they bought the iPhones and another kidney they can survive. ठीक है, मैंने अपनी अभी तक iPhone नहीं लिया है. I will sell one kidney from any one of you who will donate me. ठीक है, so देखो, now इधर देखो, there is a right kidney is there. So right kidney, we see that this is the right kidney, this is the inferior vena cava, this is the like the duct of the right kidney. Now we see this is the testicles. Here you can say, assume that is the testicle. This is the right testicles, and this one is the right testicular veins. The right testicular veins. The right testicular vein. Now see, if we having another one, the another one is what? This one. This one have the long. This is again what? That is the left kidney. This is again that is the left kidney. The kidney both are the equal. Okay. This is what? The left kidney. Now in the left kidney, what we have seen, it should be the here what should be there? The left testicular vein. But left testicular vein is saying कि मैं तो यहाँ से नहीं आऊँगी, मैं तो यहाँ से आऊँगी. ठीक है. So left testicular vein कहाँ से आएगी? यहाँ से आएगी. So this is the left. This is what? The left testicular vein. This is what? The left testicular vein. The left testicular vein is there and it's coming from the left testicles. It's coming from the left testicles. Okay. This is the left testicle and this is the right testicle. ये दोनों नजदीक नजदीक थे, बस डायग्राम की वजह से दूर दूर है. ठीक है. So the left testicular vein is directly opening. It is directly opening into the left renal vein, directly opening into the left renal vein, and this is the right renal vein. This is the right renal vein, this is the left renal vein. So the left testicular vein is directly opening where? Into the left renal veins. And we know that in case of the veins, we having some walls. Wall present होते हैं. These are the walls that present in case of the left testicular veins. Okay. Now see, when the person is standing, so normally this condition, if the person is normal, everything will become normal. But if any problem will be there in these patients, or like the patient who is having the long standing conditions, जो काफी 24 hours they are having the completely in the standing positions also. So the right testicular vein, they will drain into the inferior vena cava, then it drain into the right testicular, and then they will go up. It doesn't have any problems. But if we talk about the left testicular veins, this left testicular veins, the blood will be flowing here. Let me take the blue. So if the blood is going here, again come back. The blood is also flowing from here. The blood is also flowing from here. Now what you say, this blood will be create the resistance. They cause the resistance, and due to this resistant pressure, this blood again will come down, and cause the edema, and it will cause the edema. Okay, so that's why the most common cause of the varicoceles is that the left The most common is what? The left one, the left side. Due to, it will be due to valvular incompetence. Usually these valves having the unidirectional flow, but due to pressure they will be having the bidirectional flow. The valvular incompetence, in left testicular veins due to increase in pressures. So once the pressure will be increased, so the valvular incompetence will be there and the bloods will be going back. The blood will be going back, and that's why the problem has been started. In simple terms, if this is the horizontal flow in this directions, so the vertical flow should be in the direction, but this is provide the resistance. That's why there will the back flow of these conditions, and that will cause the edema in this region. That will cause the left testicular edema. Okay, I hope this is clear. What are the clinicals or the features or the symptoms or the signs we will see in this condition? They will see the dragging sensations. The patients will see the dragging sensation in scrotum. The dragging sensation in scrotum will be seen. The dragging sensation in scrotum will be seen. Other than that, what we will see, the patients will be having the sterility. Why the sterility? Due to temperature interference, the sterility will be there. And also this patient will be having the bag of warm feelings. The bag of warm feel. Bag of heaviness. The patients will say कुछ भारी भारी भरकम लग रहा है. That is the heaviness. The heaviness is there. So for that we will do the sclerotherapy, and also we will use the alternative route of the venous drainage with the help of like cremastic veins and all those things. But here you should understand the concept. Varicocele, abnormal dilatation of the pampiniform plexus of the veins around the testis. We will be at the right renal vein, left renal veins. So most common varicocele, this is seen in the left side because of the long left renal veins, and this left renal veins, what we see, the left testicular veins is there, that will be cause the incompetence of these valves will cause the pressure. So due to horizontal gravity, when the person is standing, so there will be the gravitational force. When the person will be down, so this there will be the less gravity will be there, and that's why this edema will be disappear. Okay, I hope this is clear. Testicles normal size, soft scrotum, limited edema. Limited edema means the edema that goes back due to some position changes or some locomotion movement, that we call the limited edema when the patient lies down. So what we call this condition as the varicoceles. Is that clear, everyone? Okay, thank you. Chalo. Then question number 4. A patient was delivered to surgical department after a road accident with a closed trauma of the chest and right side rib fracture. The patient was diagnosed with the right-sided pneumothorax. We discussed about the pneumothorax in pediatrics class. The pneumothorax means the air is filled in the lung regions. It is indicated to perform the drainage. So we need to drain the pleural cavity. Can you tell me what I told you? In case of the hydrothorax, which intercostal space I told you? How is pressure increase? किस में प्रेशर इंक्रीज होगा? The pressure increase in these conditions, this is due to, देखो, now see, when the valvular incompetence is there, the blood is flowing here, the blood is also flowing here, and when this valvular incompetence will be there, the valve will not able to work properly. So in that conditions, we will be having some resistance to this flow. And once the resistance to this flow, the backward flow will be there, and already the valvular are incompetent, that's why the backward flow will be there, the flow will be reversed, and then there will be the accumulation of the blood in case of when the person is standing. And when the person is standing means his scrotum is under the gravity. Okay, that's why they will be having the accumulation of the bloods or accumulation of the fluids, and that will lead to the edema in this lady. Once they will lie down, or they will be in the horizontal positions, means that at that times there will be these conditions will be like this. so it can easily flow directly. There will be the less pressure in that side. That's why there can be the easily flow will be there. Nobody answer. In case of the hydrothorax, fifth intercostal space, mid axillary lines do draining of the fluids. Okay. So what we have is see if the case of the pneumothorax, if the case of the this is the case of the pneumothorax, so in that cases we have the second intercostal space along the mid clavicular line. But if we having the hydrothorax, so in case of hydrothorax or hemothorax, where the fluids, water or the blood is accumulated, so at that time we will use the sixth intercostal space, and if the sixth intercostal space is not in the option, then fifth intercostal space. Okay, so sixth intercostal space along the posterior axillary lines, along the mid axillary lines. ठीक है, note along the mid axillary lines. So that is the hydrothorax or the hemothorax. Question number 5 we already discussed. Has changes of the mammary gland, what are the most often symptoms that precede the malagnizations? So malagnizations, we know that the skin indurations with the inverted nipple we see, that is the characteristics we seen in case of the breast cancers, and also this is seen in case of the PUD orange also. Okay, this is also the breast cancer conditions. The next question, name statistical observations for determination of influence amount of the blood sugar on the healing of the wound surface in the post-operative periods. So this is the answer. The patient is in the post-operative. Statistical observations means what are the observations? Statistical observations means we collect from the patient itself. So this statistical observation, it means the patient is in the post-operative periods, and at the post-operative periods we are determining the influence amount of blood sugar to, like what amount of the blood sugars will be like how much amount of the blood sugars is used to heal this wound surface. So that will be done in case of the post-operative periods also, post-operative period only. Okay, that is the statistical observations. This question will not be asked in your exams, don't worry. अगर आएगा तो डायरेक्ट क्वेश्चन आएगा, वरना नहीं आएगा. ठीक है. This is related to the hygiene question, by the way, not completely the surgery questions. A 20-year-old patient was delivered to the hospital in summer from the street with a hemorrhage from the brachial artery. एक 20 साल का आदमी है जिसने क्या हुआ, delivered in the hospital in the summer, in summer region, from the street with a hemorrhage from the brachial artery. Now what we are seeing, there is a hemorrhage, where the hemorrhage will be there from the brachial artery. The first medical aid involved the application of the tourniquet for provisional arrest of bleedings. What is the maximum exposure of the tourniquet? So if in the question they give you the summer, so in case of the summer, see, if we don't provide the tourniquet or we don't apply the tourniquet, so these patients can having the conditions like the ischemic necrosis can be there. These patients can having the ischemic necrosis here. Then why we are applying the tourniquet? To prevent the ischemic injury. To prevent ischemic injury. So in case of the summer, when we talk about the summer, then remember there will be the 120 minutes. For the summer, remember more than 120 minutes. And if we talk about the winter, as the winter the blood flow is less. In winter, that the blood flow is less, so that's why we give the less times. So that will be the around 30 minutes. Okay. So if they ask you in the summer, so means that 120 minutes. In the winters, we have the 30 minutes, because in the winter we have the less blood flow. That's why. 9-year-olds, leave these questions because this is related to the hygiene, because it have the different options, like third A. Some in the some books they wrote the third A, and some books they wrote the third B also. ठीक है. So I will see the in the test center website whatever the answer will possible, so we will mark that. Then question number 9. A 38-year-old man previously in the good health suddenly developed the severe abdominal pain radiating from the left loin to the groin regions and accompanied by the nausea, perspications of the need of the frequent urinations. He is restless, tossing in the bed but has no abnormal findings. The most likely diagnosis age. So what we are seeing, the patient is good health suddenly developed. If there is a sudden pain, if what we are seeing the sudden severe abdominal pain that is radiating from the left loin to the groin regions, from the left side to the back side and accompanied by the nausea, perspirations and frequent urination is there. So what we call this condition, if normally also you saw in your school time also to the some or maybe in normal routine also, that sometimes the people who having the kidney stones, so these people like they usually see in the good health conditions, but suddenly they got like the severe ache or the severe pain will be there and they will put the one hand here and they will scream a lot. That's we call understand that this is the can be the case of the kidney stones. Okay, so that's why we will be having the left sided renal colic. Okay, just a second. Okay, let's come back. Yeah, that is the image that the Kalagi sent, that the bird beak symptoms, that is the bird beak appearance. Okay, all these images you can see, but images they did not ask you, they ask you the direct question. That's why not showing the images also. Okay, all the whatever the important images I will send. So don't worry about the images because they will not provide you the image. Now this question we done. So if you see there is sudden abdominal pain, there is a sudden or the severe abdominal pain, and that is radiating pain will be there. Okay, so that means that is talking about the left sided renal colics. That is the left sided renal colics. Then remember also, okay, let's discuss the complete about the urinary stones little bit. So let's discuss about the urinary or the kidney stones. So when we talk about the urinary or kidney stones, so see the most common if we talk about the kidney stone, the most commonly we discuss that is the calcium oxalate stones. The accumulation of the calcium oxalate will be there, and that is the most common kidney stone. The most common kidney stones, that is the calcium oxalate stones. Calcium oxalate stone. Then after that, if we talk about the most common urinary bladder stones, the most common urinary bladder stone, that remembers that will be the triple phosphate. That is the triple phosphate stones. They are just the type of the stone, the calcium oxalate stones. The calcium oxalate stones we can call that is the monohydrate or the dihydrate. The monohydrate are the second hardest, and this is seen like if based on the urinary pH, like seen in the normal urinary pH. So they are the different type of the spikes. They are also the spiculated. They are the spiculated means they have the spikes. They have the spikes, कांटे होते हैं इसके अंदर, and due to which what we will see, due to these spikes what we see in these patients, the hematuria, what we will see, the hematuria will be there, like the nucleae होते हैं, ठीक है, तो nucleae होंगे तो spikes will be there, so that's will we see the hematuria will be seen in these patients. Then this is the triple phosphate, this is the common in children's. Then if we talk about the adults, in adults remember they have the uric acid stones, that is the most common urinary bladder stones, the uric acid stones that we seen in case of the adult. Okay, so this is the direct question that you need to remember. The most common cause again that is the idiopathic, but and in idiopathic if we discuss with like the hypothesis, if we see that due to hypercalciuria, if there is a more calcium in the body, that can be the reason of the stones will be there. It can be the hyperoxaluria, it can be the hyperuricemia. Okay, now for they will not ask you this question directly, but they will ask you, then if they will ask you, they will ask you the hypercalciuria, that is the idiopathic hypercalciuria. Other things like the urinary tract infections can be there. Other thing, there is a deficiency of vitamin A can be there. Deficiency of vitamin A can be there. Okay, the types I discussed that with you, that is the, it can be the calcium oxalate stones, that can be the triple phosphate stones. Let's write one line also in this, because you will get some in question itself. The calcium oxalate stones, the calcium oxalate stone, they are the spiculated. They are the spiculated. Spiculated means they are the spikes, and they are slightly acidic. Normally they seen in the normal pH, or if normal pH or slightly acidic pH. Normal pH or slightly acidic pH. Okay, then we can having the triple phosphate. The triple phosphate stones means triple phosphate. What is the triple phosphate? It is the stone of the calciums, magnesiums and ammonium phosphate. Calcium, magnesium, ammonium phosphate stones, that we call the triple phosphate stones. calcium, magnesium, ammonium phosphate stones. They are associated with one bacteria, that is the proteus. Associated with the one bacteria, that is the proteus. And this proteus, what they do, they make the urine alkaline. They make the urine alkaline, and they make the urine alkalines. Okay, then because why they associated with the urines? Because the proteus, what they do, this is make the urine alkaline. And this triple phosphate stones, this most of time they seen in the mostly seen in alkaline urines. They mostly seen in the alkaline urines. That's why they are associated with the proteus. Again, they will give you in the questions. They will not ask you this question directly. The other name of the triple phosphate, they are also known as the struvite. Struvite means सख्त होते हैं एकदम, सख्त लोंडा. तो सख्त पत्थर कौन सा होता है? ट्रिपल फोस्फेट. ट्रिपल फोस्फेट. Then they are the silent. They are the silent, and they are the staghorn shape. Struvite, silent, staghorn shape. That is the triple phosphate stone. That is the triple phosphate stone. There is a one more stone that you can remember. That is the cystine stone. And the cystine stone, remember, this is the hardest stone. This is the hardest stone. The second hardest stone is the calcium oxalate monohydrate, and the hardest stone is the cystine stone. And remember, these are seen in case of the what we call the cystinuria. The cystinuria, the one biological words. Okay, and they grow in where? In case of the acidic urine. They grow in case of the acidic urine. That you need to understand very, very well. The next one is what? That is the uric acid. The next one is what? That is the uric acid. The uric acid, they are the smooth. This uric acid, this is the common things, because they are in your syllabus there is a gout, so they can ask you this question also. The smooth, the round levels in shape. They are the smooth round level in the shape, and also the oval in the shape, round or oval in the shape. Then there are also what? Uric acid. Of course, they will be the acidic. They will be the acidic. They don't visible on the X-ray, so these are the radiolucent. They are the radiolucent stones. So we will get a one keyword in the question, the radiolucent. So means that is the uric acid stones. Other radiolucents, I'm just repeating or just telling you verbally that can be the parotid, it can be the gallbladder, it can be the lysines, uric acid, or the xanthines. Okay, they are the five. These are the radiolucents. The radiolucent means they not visible on the X-ray. They not visible on the X-ray. What are the clinical features we seen in case of the stones? The clinical features that we seen in case of the stones, that is the important for our exams. Remember, there will be the abdominal pain will be there, and that is the abdominal pain. That is the most common symptoms or the most common clinical feature. What are the earliest symptoms? What you will see? The frequency of micturition. The frequency of micturations will be seen. The frequency of micturations will be seen. What other findings? Hematuria. What other findings we can see? The hematuria can be seen. There can be the interruption of urinary systems. There can be the interruption of urinary systems will be there. This interruption of urinary systems, this is specially seen in case of the urinary bladder stone. This is seen in case of the urinary bladder stones. And directly they will not give you the urinary bladder stones, they will give you the large vesicle stones. Large vesicles, and the stone means calculus. Dekho, what is the meaning of the stone? Calculus. Vesicles means bladder. Urinary, the large vesicle, calculus, or the bladder stones. Okay. Now see other findings. If you see the kidney stones, in case of the kidney stones, what we will see? We see the fixed lumbar pain will be there. The fixed lumbar pain will be there. The fixed lumbar pain will be theirs. If we talk about the upper one third ureteric stones, so that means in that conditions the lumbar pain radiate to perineum regions and the testicles regions. Lumbar pain radiate to the perineums and testicles. That you need to remember. Okay. And also remember one more thing about the urinary bladder stones. Urinary bladder stones, we see the suprapubic pains. We see suprapubic pain will be theirs. Okay. So in those conditions we can check about the investigation of the choice with the help of NECT, and also we can give the diclofenac for the pain reliefs, and other things we can give the TAM solution. The TAM solution, they call the relaxation of the muscles. So the TAM solution or the diclofenac we can give, and along with that we need to check about, if we talk about the treatment, so treatment will be done based on the size of the stones. If the size of the stone is less than 5 mm, we give the plenty of the fluids and to increase the diuresis, so that the stone can be easily move out with the help of the urination itself. If the size is more than 5 to 6 mm, then in that cases we will do the treatment, we do the operations, and operations we can do the lithotropsy, or where we provide the shock waves, Then also remember, if the 16 stone will be there, that will be difficult to be broken down by the shock waves. So for that we have to do another alternative things. So here we can see the severe abdominal pain, there is a left flowing to the groin pain and frequent urination. So most likely diagnosis will be the left sided renal colic, means stone is there. Okay, other findings we will keep discussing further on. Then question number 10. A 40-year-old woman has self-detected hard breast mass. The procedure of choice for confirming the diagnosis. So see, for confirm the diagnosis, what we do the for confirmations. If any we suspect the cancer, if we suspect the cancer, for confirmations what we will do, we do the biopsy. But here in this question we will have the excisional biopsy, aspiration biopsy with cytology. So there is a type, if we talk about the biopsy, if we talk about the biopsy, so biopsy, remember, this is done to confirm the diagnosis, How we will make the diagnosis of any cancer, of like suspecting cancer? So the type diagnosis is based on the FNAC. FNAC is what? That is the fine needle aspiration cytology. So in that conditions, in case of the fine needle aspiration cytology, what we do? We take a needles. The like big needles we take, and with the help of these needles we will pierce into the swelling area, and then we will aspirate that things. Then we will check if it is which organ is there and make the diagnosis. To confirm that diagnosis we need to do the biopsy. And for biopsy, remember, these biopsy is the two types. One we having the incisional biopsy, and another one is what? That is the excisional biopsy. The another one will be the excisional biopsy. In case of the incisional biopsy, what we see, the some part of tissue is left behind, means we don't take the full tissue, some part of the tissue is left behind. In case of the excisional biopsy, what we do, we take the entire tissue, is taken out. That we call the excisional biopsy. Okay, this is we call the true cut biopsy. The another name of the incisional biopsy is the true cut biopsy, where we make the incision. For example, if we talk about the breast cancer, So in the breast cancer, we will make the incision around the areolar regions, and there is a one condition called the one gun is there, true cut biopsy gun. We call this as the true cut biopsy guns that will insert it into these incisions. Okay, and once we localize these biopsy guns, we will trigger to cut, and then we will remove the tissue, but we will not remove the entire tissue. We remove the some part of the tissues, and some part of the tissue will be left behind. Okay, so this tissue is incisional biopsy is again the important one for the breast cancer and the soft tissue lesions. So it is the best for the breast cancer and the soft tissue lesions. But if you in the questions you don't given the incisional biopsy, we can use the excisional biopsy also. Like for example, in this question what we are seeing, the self-detected hard breast mass. So we are seeing that hard breast mass is there. So procedure of choice for confirming the diagnosis. So for the hard breast mass is there, and so in that condition what we will do the excisional biopsy. If there is self-detected hard breast mass, that can be the case of the fibroadenoma. That can be the case of the fibroadenoma. So in that conditions we can take the whole tissue out, because the fibroadenoma, it is a benign conditions. So if the benign conditions, what we can do, we can take the whole tissue out, and we for confirmations what we do, we can do the excisional biopsy. In excisional biopsy also we take the whole tissue out. That's why we can cure that condition also on that things also. Okay, but this is just I am suspecting, this can be the self-detecting. So the self-detecting hard breast mass, okay, that can be the fibroadenoma, but the procedure of the choice for confirming, for any confirmation is given and you are suspecting any tumor or any cancer is there, so answer will be the biopsy. Okay, so in this question no option is given about the incisional biopsy, so that what will do the excisional biopsy. Aspiration we do when we do the diagnosis, so that we at that time we do the aspiration. The aspiration biopsy is nothing at higher levels. Question number 11. During investigation of the chronic severe epigastric pain, so what we have seen, we have the chronic, there is a severe epigastric pain, a 40-year-old alcoholic man is found to have the multiple area of the narrowing, altering with the dilatation, like there is a chains of the legs appearance of the main pancreatic duct. So if the chain of the leg appearance is given, this condition is seen in case of the chronic pancreatitis. So the chronic pancreatitis is the diagnosis, but they ask you the operation or the surgical method we do, that is the lateral pancreatojejunostomy. Okay, so let's come back. Acute pancreatitis. See, when we talk about the acute pancreatitis means what? Acute inflammation of the pancreas. The acute inflammation of pancreas. The acute inflammation of pancreas. Okay, that itis means inflammations. What we will see in this condition? We see there is a sudden severe abdominal pain. The sudden severe abdominal pain. The shock can also be seen. Along with that, we see there is an increase in the pancreatic enzymes. There will be the increase in the pancreatic enzymes will be there. The most common cause of the acute pancreatitis, is the gallstone. The gallstone is the gallstone. And the second most common cause is the alcohol. and this is the reverse in case of the chronic pancreatitis. In chronic pancreatitis, the most common cause of the chronic pancreatitis is alcohol. The second most common cause of chronic pancreatitis is the gallstone. Okay, so that is what most common cause and the second most common cause. Okay, if we talk about the children's, it is can be the hereditary or the trauma infections. So where I was, the most common cause we have that is the gallstone, and the second most common cause will be the alcohol. What are the clinical features we will see in this condition? See, the clinical features, remember, there just I told you there is a sudden severe abdominal pain. Sudden severe abdominal pain will be there because it is associated with the gallstone. But this severe abdominal pain, it will radiating to the back side. It can be the right or it can be the left sides, anything. Then the other features, see this, with this line you can easily make the diagnosis. Relief on sitting. Relief on sitting with bending forwards. Relief on sitting with the bending forwards, aggravated in supine positions. The aggravated in case of the supine positions. Okay, so relief on sitting with the bending forwards, aggravated in case of the supine positions. Along with that, we see these patients will be having the nausea, vomit. There was a direct line in the question. There was the direct line in the question. Then the question they will give you the relief on the sitting with the bending forward, aggravated in the supine positions, means they're talking about the pancreatitis. Other than that, we can having the nausea and vomiting will also be seen. Along with that, we can having the ascites, pleural effusions. Ascites means abdominal edema, and the pleural effusion can also be seen. There is one question about hemorrhagic pancreas. So if you see the bleeding in the retroperitoneums, if you see the bleeding in the retroperitoneum, so remember that will be the conditions is known as the acute hemorrhagic pancreas. Acute hemorrhagic pancreas will be the answer. If bleeding in the retroperitoneums, and this bleeding will be accumulated in the retroperitoneums, we will see the two signs. And in these two signs, we will be seeing the bluish discolorations. If we see the bluish discolorations on the flanks regions, bluish discoloration on flanks region, or bluish discoloration on umbilicus. So bluish discoloration on the umbilicus. If flank region bluish discoloration, we call this condition as the Gray-Turner signs. The Gray-Turner sign. If bluish discoloration on the umbilicus, then we call this condition as the Cullen signs. We call this as the Cullen sign. These both signs are so important. Okay. Flank region, I hope every one of you know the area like that is present area on the side and also like little back of your abdomen. The side or little back of your abdomen is the flank regions. Okay, if this is my body, so at these regions what we will see, this is the flank region. This is the flank regions. This both side are the flank regions. Okay, so this one is the flank regions. That we call this as the Gray-Turner signs, FGT. Okay, FGT and UC. You see that umbilicus is the Cullen sign. You see the umbilicus is the Cullen signs, or you can say the UC. That is the umbilicus, we have the Cullen signs. If the bleeding will be more, bleeding will be there, the patients can go into the shock also. The patients can get the shock also, and the shock symptoms you already know. There is increase in the heart rate, there is increase in the respiratory rate, there is a decrease in the blood pressure. Okay, so that you need to understand. Also, sometimes they will give you in the some questions, they will not give you this type of the history, but they will give you about the pancreatic enzymes. So if the pancreatic enzyme given, then also you can make the diagnosis. What diagnosis you can make? The serum amylase will be increased. The serum amylase will be increased. Okay, the serum amylase will be increased, immediately will be increased. The serum amylase, this is the most important marker of acute pancreatitis. If the serum amylase is increasing, is the most important marker of the acute pancreatitis. But this is non-specific. The non-specific. Why non-specific? We also seen in case of the cholangitis. Also seen in cholangitis. The cholangitis, I think we discussed in case of the pedia, where we also see the serum amylase increase. Okay, if it is more than 3 times, acute pancreatitis is the answer. If more than 3 times, acute pancreatitis is the answer. Then remember that one specific, एक और हो जाए specific. अगर नॉन स्पेसिफिक बोल रहे हैं तो एक स्पेसिफिक भी तो कर लो. तो स्पेसिफिक में क्या आएगा? The specific enzyme will be the serum lipase. The specific enzyme will be the serum lipase, and it starts increasing after 3 days. Start increasing after 3 days. Okay, so what we having, that is the specific, that we having the specifics. So that is what acute pancreatitis. Acute pancreatitis, not pancreatitis, acute pancreatitis. ठीक है. If it will not collect the blood or not aspirate the blood, it can lead to the pancreatic abscess, it can lead to the pancreatic necrosis, it can lead to the pseudocyst of the pancreas also can be there. So all these conditions can be the complicated. The next one is the chronic pancreatitis, because the both are the important topics, that's why I am taking the time here. If chronic pancreatitis is there, chronic pancreatitis, in case of the chronic pancreatitis, remember the most common cause is the alcohol. The second most common cause is what? That is the second most common cause is what? That is the gallstone. That is the gallstone. Okay. Chronic pancreatitis is irreversible conditions. It is the irreversible conditions, and in this condition, what we see, the pancreas cellular atrophy. The pancreatic जो cells है, the pancreatic cellular atrophy, their size will be reduced, and once the size will be reduced, of course that will be not be reversibles, not be reversibles. Along with that, we see the calcifications. We will see the calcification also. And the chronic pancreatitis, it is more common in the males people. Then symptoms, remember the clinical features. What the clinical feature you will see? You will see epigastrium pain. The epigastric pain will be seen, and the epigastric pain, what you will see, the pain after increase after meals. Where you studied the pain increase after the meals? In which other conditions you studied that there is pain increase after the meals? Can you write? The pain increase after the meals, in which conditions we wrote? The pain increase after the meals, in which condition we wrote? GE. What is the GE? Gastric esophagus symptoms. Duodenal ulcer or the peptic ulcer? Duodenal ulcer or the gastric ulcer? In which ulcer? Duodenal or the gastrics? Both was different. Peptic, gastric ulcers was there. ठीक है, not duodenal ulcer. So the increase after the meals, it is seen in case of the gastric ulcers. In duodenal ulcers, it will be different. The increase, it will be after the 2 hours. Just remember the concept. Once you take the meals, firstly it will go to the stomach, so it will be increased after the meals. From stomach to the duodenum, it will take some hours, like 1 hour, 2 hours, so it will be increased after the few hours. So that is the duodenal ulcers, it will be more after 2 hours. After that, what we will see, the malabsorption. Why? Because pancreas is also involved in the absorption, so that's why the malabsorption will be there. We know the pancreas produce the hormones also. That's why these patients will be having the diabetes mellitus के भी शिकार होंगे. These patients will be having the diabetic mellitus also. Then your questions. If we see the MRCP or ERCP, MRCP or the ERCP, magnetic resonance cholangiography, endoscopic retrograde cholangiopancreatography. So in that condition, what we will see? Chain of lakes appearance. The chain of lakes appearance will be seen. Chain of lake appearance will be seen. They ask you the management also. There is a one management also. I think in the croak one question that yes, in the croak one question, I think there will be the pancreatin something. So if malabsorption is there, so we can give the pancreatic enzyme supplementations like pancreative, or you can write the pancreatic enzyme supplementation, because the drugs can be the different. The pancreatic enzyme supplementations will be there. So if something related to like the pancreatogymines, pancreatoflat, pancreatocreams, so that all are the drugs for the malabsorption, or the related to they are the pancreatic enzyme supplement. Okay. In case of the diabetes mellitus, insulin will be given. If the pain is there, so in that conditions we have the problem with the malabsorption. The malabsorption problem, that's why these patients will be advised to take the small frequent meals. The patients will be advised to take the small frequent meals should be there. Okay. What are the surgery or the operations we will do? The surgical operations, we call this condition as the longitudinal or side to side pancreatico jejunostomy. The pancreaticojejunostomy. देखो, whenever if you don't know about the surgery options or the surgery, so if you are seeing that there is involved in some option, in one option only there is involvement of the jejunum, and you don't know which options would be correct, which options will be there, mark the jejunum. Because jejunum एक ऐसा भोला प्राणी है, बहुत ही simple person, he is a simple person who can adjust with everyone. So if any problems, we will take the jejunums and then we will join with the other organs. Like here in these conditions, we will be having the side to side, along with the side of the pancreas, we will join the jejunums. So if this is the pancreas, along with that we will join the jejunum. So whatever the materials will be in the pancreas will be go directly into the jejunums. Whatever the material in the pancreas will go directly into the jejunums, and that's why we can stop the drug. But we will advise these patients to take the small frequent meals so that it will be easily absorptions. And also we can call this also known as the Frege operation. This is also known as the Frege operation. Okay, so this is about the chronic pancreatitis. Okay, the longitudinal or the side to side pancreaticojejunostomy or the Frege operations will be the answer. Okay. In case of the acute pancreatitis, surgery is not required. That's why we have the chain of the lakes appearance, and the chain of lakes appearance means that the chronic pancreatitis, the operation of the choice will be the side to side. Side to side means lateral. Lateral pancreatojejunostomy will be the answer. The other name of this operation is the Frege operation. The other operation's name is the Frege operation. ठीक है, ओके. The treatment of the choice of the duodenal obstructions caused by the, so we have the duodenal obstruction is there, that is caused by the secondary duodenal hematoma that developed a few days after the blunt abdominal injury. So in this question can we having, see sorry, this patient is having the duodenal obstructions. We discussed that in pediatrics, duodenal atresia. Can you tell me how many bubbles we will see? Okay, tell me the single bubble sign. Single bubble sign, in which condition we discussed? Single bubble sign is seen in. Single bubble sign is seen in. Double bubble sign is seen in. Single bubble sign is seen in. Double bubble sign is seen in. Triple bubble sign is seen in. Okay, tell me single bubble sign. Pyloric stenosis. Single bubble sign, pyloric stenosis. Triple bubble sign. Triple bubble sign is seen in which condition? Triple bubble sign is seen in which condition? Triple bubble sign is seen in which condition? बता दो jejunal atresia. ठीक है, एंड डबल बबल साइन दिस इज सीन इन केस ऑफ द, मैं बताऊंगा duodenal atresia में. ठीक है, सारे तुम ही थोड़ा ना बताओगे, मैं भी तो कुछ बताऊंगा. So that is the pyloric stenosis, duodenal atresia, and jejunal obstructions or jejunal atresia, jejunal obstruction basically. Okay, or it can be the duodenal obstruction also. So that's why if you have the duodenal obstructions, what we have to do, it is caused by the secondary duodenal hematoma. If any obstruction is there, so in this question they are asking directly what is the, if there is a duodenal obstruction is there, we don't know, we don't care like how the obstruction is there, but obstruction is there. So in the case of the obstruction, what we need to do, we having the any obstruction, so we cannot pass the food through the duodenum. That's why we have to put the nasogastric decompressions, and we need to provide the parenteral alimentations, because there is a problem with the there is obstructions in the duodenum. That's why the food will not able to push through the into the jejunums or into the small intestines and the large intestine. That's why we will give the parenteral alimentation. That is the so simple questions that they asked. So what is the treatment of the choice of duodenal obstructions? Already there is obstruction is there, so in that condition, that's why we will give this patient as a direct the parenteral alimentations. Okay. बारह, 210, 230 क्वेश्चन, 230. Okay, so like I think it's okay. I hope you understand till now. ठीक है, समझ आया? हाँ और ना, यस और नो. नहीं समझ में आया? ऐसा नहीं, और किसी को नहीं आया? ठीक है, ओके. सो सी, एक चीज और बतानी थी. पोएम अच्छी लगी? मैसेज करके बताओ, क्या ये खेलने लग जाते हो? पोएम अच्छी लगी सबको? One thing I wanted to say कि those students who said me कि I did not prepare for this exams, I did not revise this exams. आई नीड दिस मोटिवेशन, प्लीज सेंड मी टू। मैं इसकी एक वीडियो बना के ना यूट्यूब पे डालूंगा, तो उसको बार बार शेयर कर देना, ठीक है। एक्चुअली माई वॉइस इज नॉट सो गुड ना, सो दैट्स वाई द प्रॉब्लम, अदरवाइज तो मैं सिंगर बन जाता। हाँ, आई वॉज सेइंग कि सम वाज सेइंग कि भाई आई डिड नॉट मेक द रिविजन्स, है ना, दैट्स व्हाई आई डिडंट राइट द टेस्ट। सो प्लीज डोंट गिव मी दिस एक्सक्यूजेस, आई डोंट वांट इट टू बी सीरियस, क्योंकि तुम अच्छे बच्चे हो, पढ़ने वाले हो सारे के सारे, यू आर ऑल आर द गुड स्टूडेंट्स, डोंट मेक मी सीरियस, and let's it be in the fun, and let make this fun as the greatest score in our exam. Okay, those students who was having the problems, so देखो, this everyone having this kind of the things will be there in everyone, like you will feel the disconfident, somebody write me today, then you will be having some overthinking at these times, you will be discouraged, you will think अरे यार सब कुछ पता नहीं, कुछ याद ही नहीं है, so these things it happens with everyone. Okay, those students who didn't write the exams, everyone write that they didn't revise these things. Believe me, many of the students, they did not revise the things, but still they got the better marks. They just joined few, I think in the middle of our syllabus, then still they completed all everything. So don't do this type of the things. Make sure that this 1 month, एक month बस अपना 100% अपना दे दो, give your 100% in this 1 month. I am not saying to give your उसके बाद जो भी करना है, if after that you will have the times, you will want to spend the times with your girlfriend, boyfriends, your friend, anyone, then spend the time, but for this 1 month please give me your 100%. Pain while having the meal is gastric ulcer, and pain after having the meal is peptic ulcer, right? The pain having the meal is the gastric ulcer, and pain after having the meal is the duodenal ulcer, ठीक है। Usually peptic ulcers, it involves the both, ठीक है। That's why we are not taking the peptic ulcer, because the Crow 2 question they write something in the peptic ulcer for the both condition. That's why I'm saying that pain while having the meal is the gastric ulcer, and pain after having the meals, after 1 or 2 hours, it will be the duodenal ulcer. Okay, so please keep revising. Do you want the revisions of the PD or obstetrics? One line revisions. Or should I upload it on the YouTube for all the students, or should be specific for you only? अरे यार मैसेज पर बता दो भाई, अभी तो मैसेज तो कर लो। नहीं, should I make it the public video or like just for you only? That I wanted to ask. Only when will be fine. हाँ, it will be like the Croc 1, जैसा वो Croc 1 rapid revision था ना, just for the pediatrics and obstetrics I have, ठीक है। Obstetrics and pediatrics I have, and I think rest of I don't know where I have, because some I wrote in during my Croc 2 exams, all those Croc 1 types, ठीक है। Okay, once I will free, I will make a small video and I will publish that, so that it will be from the Croc base only, ठीक है। And mostly we will just do the pedia or the obstetrics, so that's why I'm saying be focused on the surgery or the therapy part, ठीक है। Hygiene soon we will start on our WhatsApp group only, in the Croc 2 discussion groups, the public group, there I will discuss, because they say that like no one knows about the hygiene, that's why we will make it public. Okay, so see you tomorrow, bye bye, good night. We have lost the 4 days where मेरा काम भी नहीं हो पाया ना, तुम्हारा भी टाइम वेस्ट हो गया, मेरा भी टाइम वेस्ट हुआ. Okay, so see you tomorrow, bye bye, good night, take care.